Thank you, audience, for being here. This is my first time teaching at the Brigham Review course, and it's a wonderful setting to be here. So my disclosure slides are here. So I'm going to have a case that runs through this lecture. And it's a representative patient who has this disease, membranous nephropathy. So 52-year-old male who presents to a PCP clinic with several months of weight gain and lower extremity edema. Blood pressure is a little bit high, but the lungs are clear, heart sounds are normal, no evidence of heart failure, but there's 3+ pitting bilateral edema up to the knees. The lab results come back with a relatively normal creatinine, a serum albumin that is low at 2.9, and a total cholesterol that is high at 386. The urinalysis shows 4+ proteinuria with trace blood and no leukocyte esterase. So due to this explained nephrotic syndrome and a 24-hour urine collection that showed 13 grams of protein, the patient is referred to one of you, nephrologist, who schedules a kidney biopsy. The biopsy comes back, perhaps read by an eminent renal pathologist such as Dr. Renke, as membranous nephropathy, with IgG and C3, complement factor 3, present as fine granular deposits in a capillary loop pattern. There's no glomerular scarring, no FSGS, no tubular atrophy, or interstitial fibrosis. So we're going to try the audience response system here. So which of the following statements about primary membranous nephropathy is incorrect? And I understand that the board's questions don't like this format of which is the wrong answer, but we're going to do this here. So again, which is the wrong answer? That membranous affects males twice as commonly as females, that membranous nephropathy can affect Caucasians, blacks, and Asians. The median age of onset is in the mid-50s. Hypertension at presentation is very uncommon, or that 30 to 40% of patients may undergo spontaneous remission. So I'll give you a few seconds to think about this. Okay, let's see what we came up with. Okay, good. So there's a spread of answers, but most of you chose the correct one, D. So hypertension is actually present in 30 to 40%, which makes sense. It's a disease of nephrotic syndrome. You're accumulating salt and water in the body. So these middle-aged men often have high blood pressure. So just to go through the answers again, it is common in males, about 2-to-1 ratio men to females. It can be seen in all races and ethnicities all over the world. Typically, although it can start in the adolescence, primary membranous nephropathy is most common. The median age of onset is the 50s. And if left untreated, about 30% or 40% will go on to spontaneous remission. All right, so what is membranous nephropathy? Well, it's a leading cause of nephrotic syndrome in adults. It vies with FSGS as the most common cause of nephrotic syndrome, primary nephrotic syndrome. It's an autoantibody, or at least an antibody-mediated kidney disease. The primary form is an autoantibody. The majority, 75% or so, of membranous nephropathy is primary, otherwise known as idiopathic. We'll get to that in the next slide. But it's an organ-specific autoimmune disease that has a variable course. As I mentioned, about 1/3 of the patients may undergo a spontaneous remission. Some may have persistent nephrotic syndrome with stable renal function. Others may go on to end-stage renal disease, and it's a disease that can recur in the allograft. So that's the primary form. Secondary disease, membranous nephropathy, can be secondary to lupus, so class 5 lupus nephritis, Hep B infection, certain cancers and solid tumors, and certain drugs like NSAIDs, previously gold salts, penicillamine, butylamine, etc. And then there's an alloimmune form, so that the humoral response is to a protein other than what's found in the body. This has initially been described by Pierre Ronco's lab in 2002, in which a mother who was deficient in a protein called neutral endopeptidase gave birth to a fetus who had this gene from the father, and the maternal antibodies crossed the placenta to cause neonatal membranous nephropathy in the infant. There's also a form of alloimmune disease that can occur in de novo post-transplant. So a patient who did not have membranous nephropathy to begin with gets a kidney transplant, and then years down the road gets the pattern of membranous nephropathy, this is also probably due to alloantibodies in the recipient against the donor kidney. But these are rarer forms. So I just want to go over a few points at this point. So membranous nephropathy, you may have heard this before with other diseases, is just a pattern that the renal pathologist will describe. So like MPGN, like FSGS, it can be due to a number of different etiologies. Now, idiopathic membranous nephropathy is the term you find in most of the textbooks. It's becoming, in my opinion, a rarer and rarer entity as we learn the antigens and autoantibodies that are involved with this disease. So I like the term primary MN, membranous nephropathy, to distinguish from secondary disease. And primary membranous nephropathy can be broken into the antibody and antigen systems that we are learning about. So you may have a PLA2R associated membranous nephropathy, or this newer antigen that I'll talk about, THSD7A. So those are just key terminology points I'd like you to remember. So the natural history, and this is mostly, I'm talking about primary disease, has an insidious onset as compared to a disease like minimal change disease, where a week earlier the patient may be normal and then a week later be completely nephrotic and anasarchic. So in membranous nephropathy, the onset is very slow, may take months to even years to be detected. But patients often report to their primary care doctor, to their nephrologist, with weight gain, with leg edema, that they may not have noticed, but when they think back, has progressed over the course of weeks to months. Because of the slow onset, and it takes a while to realize this, about 75% of patients are nephrotic at presentation. But 25% do show up early. They're caught before their proteinuria is greater than 3.5 grams per day. But half of these will go on and progress. You've just caught them a little bit earlier. I mentioned that there's a variable course. About a third of the patients will undergo a spontaneous remission. A third will remain proteinuric but won't advance to worsen kidney disease. But a third will, and these are the ones we need to identify quickly and treat them with immunosuppression, because they do progress inexorably towards end-stage renal disease, especially when they have very heavy proteinuria. And an important fact to remember, just like the onset can be slow, the resolution of membranous nephropathy is also slow. Again, it doesn't stop immediately when you give them steroids like minimal change disease within a few weeks, but it often takes months, maybe even years, before a complete remission can be attained. And we'll go over why that is. So just a few pathologic pictures. On the left here is the PAS stain, showing the thickened basement membranes that's seen in membranous nephropathy. There are a lot of open capillary loops. This is not a proliferative disease. You don't see an exudate of inflammatory cells in the glomerular tuft. And that's why I discourage the use of membranous glomerulonephritis, because it really isn't a inflammation within the glomerulus. So I like the term membranous nephropathy or membranous glomerulopathy. On the right, we have a silver stain, and remember that silver stains the normal glomerular basement membrane. And although more typical, you see the spikes that are the deposited GBM material between the deposits. This shows another finding, the pits or craters that are actually the immune deposits that are not stained by the silver. So you can either see the spikes or the pits and craters or both in the silver stained image. I think more pathognomonic of this disorder is the fine peripheral capillary loop immune deposits seen. And I put both IgG and C3 here because the patterns are identical. Within this deposit is both antibody, complement, and the antigen. And finally, I think this is the most likely thing you might see on the boards in terms of a picture of membranous nephropathy. So you have the capillary lumen here with an immune cell that just happens to be passing through. You have a normal fenestrated capillary endothelium, and then these electron-dense deposits are on the abluminal side, so under the podocyte, under the visceral epithelial cell, present as these darker deposits. And the podocyte itself no longer has the interdigitated foot processes that wrap around the capillary loop, but this simplified, effaced form of the podocyte. And also another sign of the podocyte injury are these membrane projections that's called microvillous change. So remember this image. Again, an electron micrograph of membranous nephropathy. And here I just point out that these deposits contain, as I said, antibody complement factors C3, C4, as well as the antigens, which we'll talk about in a minute. This is from a review we wrote for the Journal of Clinical Investigation a few years ago, and it shows nicely, I think, how these deposits might form. So most of membranous nephropathy is primary, and we know in primary disease that the antigen, either PLA2R, THSD7A, or perhaps some other unknown antigens, sit intrinsically on the podocyte. So there's these little capsule-like depictions here, and circulating antibodies that form for various reasons, we don't quite know, cross the GBM, bind to the intrinsic podocyte antigen, and cause shedding of these deposits into the subepithelial space. So this would be a deposit in primary disease. There are certain secondary diseases, hepatitis B-associated membranous nephropathy, in which the antigen is positively charged or cationic. This also has been reported in experimental models and recently in a pediatric disease, again by Pierre Ronco, in which milk products, altered bovine serum albumin is absorbed by the infant gut, and the cationic BSA crosses the GBM based on charge, plants in a subepithelial location, and then antibodies can be formed against that. So that's the planted antigen. And finally, there's not a lot of great evidence for this, but I think the assumption in class 5 lupus nephritis is that there's circulating complexes of ANA, anti-double-stranded DNA, and DNA or histones that ultimately get trapped in a subepithelial location. So 3 possible mechanisms on how these immune complexes are generated. So let's go back to our case. The nephrologist is unsure whether or not this membranous nephropathy found on biopsy represents primary or secondary disease. So she requests that her patient's serum be tested for anti-PLA2R antibodies. Now, what are these antibodies? So our lab at Boston University with David Salant reported in 2009 that the major target antigen in membranous nephropathy is a protein that we really had never heard of before called the M or muscle type phospholipase A2 receptor. And essentially, PLA2R, phospholipase A2 receptor, is shown in red here. So this is a podocyte protein. And then when a patient develops autoantibodies to this protein, so over here is the normal kidney. This is a biopsy of a membranous nephropathy kidney. And no longer do you see PLA2R in the cell, but it's all translocated. It's all been shed into these immune complexes where the red PLA2R now co-localizes with IgG. So you get a merge of IgG and PLA2R. I just want to point out, because this is confusing, the antibody we used in this study to PLA2R, which lights up the podocyte very nicely, is not the same one that renal pathologists are using. The current commercial antibody that's being used by renal pathologists does not stain the podocyte well and only shows up well in the deposits. So what are the tests out there? There are 3 tests for the circulating antibody. Early studies, including our lab, used Western blotting. It's the most sensitive, but it's also impractical for clinical use. So currently there are 2 types of commercial tests available. One is an indirect immunofluorescence assay that basically takes a biochip, cells on a slide that have been transfected with this protein, and what's being asked is, does the patient's serum light up these cells versus a control cell? It's rapid, it's semi-quantitative, but I think the more useful assay is the ELISA, which has recombinant PLA2R on the microwell plate. The patient's serum is added, and you can quantitatively assess how many anti-PLA2R antibodies are in that patient. Finally, this isn't a test for anti-PLA2R, but is a test for the antigen within the deposits. And more renal pathologists are now staining the biopsy tissue for the antigen. And just like you see the peripheral capillary loop granular pattern for antibodies, IgG, complement, you also see that same pattern when you look for the antigen. So everything is co-localized within that deposit. So to recap what we know about this anti-PLA2R, PLA2R system, We know it's a normal protein in podocytes. We know that patients who have clinically active primary disease, 70 to 80% of them will have circulating antibodies to PLA2R. In disease, in membranous nephropathy, we know that the antigen, PLA2R, is shed from the podocyte and it co-localizes with IgG in the subepithelial immune deposits. Another nice piece of evidence implicating PLA2R came from a European cohort where they did a genome-wide association study looking at cases of membranous nephropathy versus European controls and found two major signals in the genome. One was in the gene for PLA2R, PLA2R1, and another was in a class 2 MHC molecule, HLA-DQA1. We know that the finding of anti-PLA2R in the circulation or the tissue PLA2R in the deposits is highly specific, 100% specific for membranous nephropathy. Whether it's specific for primary versus secondary is a little more open and more controversial, and I'll show some slides about why that may be. But we know that there's a very strong association of the levels or the titers of anti-PLA2R with the clinical disease activity. So back to our case. So the patient is indeed found to be positive for circulating anti-PLA2R at a moderately high titer, and the renal pathologist has stained the biopsy sample for PLA2R, which, as expected, shows a strong staining for PLA2R in a fine peripheral capillary loop pattern. But a question is raised, could this still be secondary disease? So just to recap, primary disease, I'm talking about PLA2R associated, this other antigen, THSD7A associated, or idiopathic, which I reserve for those cases that seem to be primary, but for which the antigen has yet to be identified. Or is this secondary? Is it lupus, class 5 lupus, Hep B associated, malignancies, certain solid tumors, or CLL, drugs or toxins, or this very rare disease, cationic BSA, which is found largely in infants. So let's go back to the audience response system. Which of the following findings on biopsy would favor primary disease rather than secondary? So A, positive staining for C1q in the deposits. B, a hazy podocyte cell body staining for PLA2R. Predominance of the IgG4 subclass. Presence of subendothelial and mesangial deposits, or endothelial tubular reticular inclusions. Okay, let's close it now. All right, so something between B, C, and D, and let's look at these. Okay, the answer that I was looking for, whoops, don't want that, clicked on this again. Okay, so the correct answer was IgG4 subclass. But, so positive staining for C1q, it's typically found in lupus, class 5 lupus, endothelial tubular reticular inclusions as well. I think the PLA2R staining, I confused you. The staining should be within the deposits. This hazy podocyte cell body is something you see in normal tissue, so that's not what I wanted. And subendothelial and mesangial deposits are more typical of lupus-associated membranous. So IgG4 is the correct answer and tends to suggest that this might be a primary disorder. So primary disease, again, this pattern is typical, and you'll find IgG, which is typically IgG4, complement factor 3, or 4 if you look for it, and staining for one of the two antigens. That would signify primary disease. Secondary, you may have IgA, IgM, or C1q, which would give the full house pattern with IgG and C3. You may have a subclass other than IgG4, IgG1, 2, or 3, and you wouldn't find PLA2R or this other antigen 7A within the deposits. So this didn't come out in your printout, but I think the PDFs will show this. So again, it looks at the comparison between primary and secondary disease. So primary has an intrinsic podocyte antigen, such as PLA2R. You can stain for that in the antigens. You may find IgG and C3. Tends to be IgG4 predominant, only subepithelial deposits, and will stain for the relevant antigen. Versus secondary, where you may have deposition of immune complexes or planted antigens. You have secondary causes. You may see the full house immunofluorescence pattern. If your pathologist stains for the subclasses, you may see something other than IgG4, mesangial and subendothelial deposits, with no staining for PLA2R. And there's one report in malignancy that there may be, if there are more than 8 infiltrating immune cells, that might be a marker for malignancy-associated membranous nephropathy. A study we did with a group in Nanjing shows how it's difficult to convincingly say this is primary versus secondary disease. So they had a group of 60 idiopathic patients, and 80% of those were anti-PLA2R positive. But they also had groups of lupus-associated membranous, hepatitis B-associated, and cancer-associated. And the majority of those so-called secondary cases did not have circulating anti-PLA2R, as would be expected. And when the lead author, Wei-Song Chin, looked at these biopsy samples, just like I said, secondary disease, you don't have IgG4, and lo and behold, there was no IgG4 in their deposits. But there was also a group of patients, 1 in each of the lupus and hepatitis B associated, and 3 in the cancer, that did have circulating anti-PLA2R. When Wei-Song went back and looked at those biopsies and stained for IgG4, they all had IgG4 within the deposits, suggesting that maybe this is primary disease, and they just happen to also have a positive ANA or be hepatitis B associated or have a malignancy. You know, in 50, 60-year-olds, it's not uncommon to have a cancer that's detected around the same time of membranous. So I think we need to look at this association. Is it just an association, or is it causation in some of these cases that we're calling secondary but have features of primary? And it's not a resolved issue at this moment, and there's no really good way to figure this out. So thinking about the possible tests, the circulation, anti-PLA2R circulating, or the tissue. So early in disease, as the humoral immune system is just starting to make these, you may have an undetectable level in the circulation just because the kidney acts as a sink and soaks up all these antibodies, and you might get a very weak signal. As the disease progresses, your antibody level in the circulation goes up, and then a little later, you'll actually find that the proteinuria lags behind the clinical response. So the antibodies levels can go from low to high, and then with treatment or remission, the antibody levels can go from high to low to negative when the patient achieves an immunologic remission. The thing to note here is if the disease has already run its course, because we know the proteinuria lags behind, the patient may have significant proteinuria but have a negative level. So how do we know this is PLA2R associated disease? So sometimes staining the biopsy tissue and showing that they have this marker of previous disease, PLA2R within the deposits, is important to say, okay, this patient had the disease, is now immunologically inactive, and maybe we can just follow them to see if they go into a partial or complete remission within a few months. So I've been mentioning this other antigen, again, a name that we'd never heard of before our mass spec analysis pulled this up, and this was done in collaboration with a group from Hamburg, Rolf Stahl's group, and a group from Nice, Gerard Lambeau's group. And what we found was there's a very small percentage of patients with primary disease that had antibodies to a similarly sized but different protein than PLA2R. And it turns out that this protein is perhaps an adhesion molecule, we're looking at this now, but a thrombospondin domain-containing protein that I abbreviate as 7A because it's too tough to say THSD7A. But basically, when we eluted IgG from the deposits, we found that patients who had anti-PLA2R in their circulation, the IgG that came from their biopsy tissue only recognized PLA2R, not THSD7A. Patients with lupus didn't recognize either, but these very rare patients that had this THSD7A associated membranous nephropathy recognized this new antigen and not PLA2R. But you can think of it, it's very similar. So it's a podocyte antigen. When antibodies target it, that antigen is shed into the deposits where it colocalizes with IgG. So in D here you see this yellow colocalization of IgG4 and this new antigen, THSD7A. So I think we'll see a little more on this coming out in the future as we find more and more of these cases. Okay, back to our case. So the nephrologist looked for cancer using age-appropriate screening, didn't find any evidence of cancer, and the patient was conservatively managed with diuretics, ACE inhibitors or ARBs, statins over the next 6 months, and the blood pressure came down a little bit. Creatinine remained roughly stable. The serum albumin stayed at 2.9, but the 24-hour urine only came down to approximately 11 grams. So the patient and nephrologist discusses the benefits and risks of treatment with immunosuppressive agents. Now, it's a tough decision, as any of us who have treated membranous know. There are risks of therapy, so infections, you're suppressing the immune system, cytopenias, infertility with alkylating agents, malignancies, and nephrotoxicity with the calcineurin inhibitors. But there are risks of no treatment. In addition to the dyslipidemia, volume issues, high blood pressure, the risks of venous thromboembolism, especially renal vein thrombosis, which tends to be seen in membranous nephropathy, and pulmonary embolisms. There's a recent study out of UNC in Toronto that shows that it's not just venous events, but also arterial cardiovascular events that may be increased in membranous nephropathy. There are other considerations about the cost of coverage, insurance coverage for these treatments, and patient-specific factors that may have you pick one versus another. So I just want to talk a bit about this venous thromboembolism. So the groups from North Carolina and Toronto have pooled their databases and shown that in membranous nephropathy, the risk of venous thromboembolic events is anywhere between 10 to 40%, and increases as your serum albumin falls below sort of a threshold level of 2.8. So they performed a Markov decision analysis based on 539 patients that they could look at events in. And they predicted benefit to risk ratios according to bleeding risk, and this was based on the Atria study, looked at age, prior bleeding, et cetera, and serum albumin. And what they found was if a patient's a low bleeding risk, young, has never had prior bleeding, doesn't have hypertension, generally it's a good benefit to risk profile. So if your albumin's less than 3, you have a 4.5 benefit to risk. If your albumin's lower than 2, this puts you at very high risk for a thromboembolic event. So it's well worth the risk of treating. But as you accumulate more risk factors for bleeding, you may not benefit as much from anticoagulating that patient. So another therapeutic dilemma that we face in membranous nephropathy, to add warfarin or not. But most people will start conservatively using an ACE inhibitor or an angiotensin receptor blocker, diuretics, statin to control the dyslipidemia, and maybe warfarin. Generally, if there's no resolution in 6 months, and I'll go over what that means, the treatments have been either an alkylating agent with prednisone or a calcineurin inhibitor. Alternatives include rituximab, mycophenolate, or ACTH. And I should probably mention in a course like this that none of these are FDA approved for the treatment of membranous, except actually ACTH, which in the 50s was approved in general for the treatment of nephrotic syndrome. What we want to avoid is corticosteroid monotherapy or mycophenolate monotherapy, which really do not work to treat membranous nephropathy. So this is from the KDIGO 2012 guidelines. Is immunosuppression indicated? Well, yes, if you have nephrotic syndrome and your proteinuria is greater than 4 grams and it's been like that for 6 months, or if you have severe life-threatening, such as a PE or disabling nephrosis, or if your creatinine is, for other reasons, rising and you don't have any other explanation. You don't want to treat patients who have an infection with immunosuppression, or if they have small atrophic kidneys or their creatinine's over 3.5. These patients have already progressed and further immunosuppression is not going to do them any good. So this is based on a algorithm that Dan Catron in Toronto has developed, looking at the risk. So generally, if you have less than 4 grams a day of protein, you're at low risk, and you're going to be observed if your blood pressure is okay, just with conservative therapy. If you're in the moderate risk, 4 to 8 grams a day, you have about 6 months to try to get that patient under control. So if with conservative therapy, if their proteinuria drops below 4, you can continue to monitor. But if at 6 months they're still greater than 4 grams, you should think about treating with immunosuppressive agents. And then the highest risk patients are those with greater than 8 grams a day. You have less of a time. The window to decide on treatment is about 3 months here. But if their creatinine's getting worse, if you can't get them sort of to a less than 4 gram a day, you should treat these patients as well. And the choices are alkylating agents with prednisone, calcineurin inhibitors, or rituximab is emerging as a potential first-line agent. So some of the data, the longest, best data that the KDIGO looked at and said this is our first-line agent is based on alkylating agents combined with prednisone. This is the Ponticelli or the modified Ponticelli regimen. So it's a 6-month course. Months 1, 3, and 5 start with 3 days of pulse steroids, following by oral corticosteroids. Months 2, 4, and 6 are the alkylating agent. The initial one was chlorambucil. It was found to have more adverse effects. So the modified Ponticelli uses cyclophosphamide. And we know that at 10 years, that renal survival, the avoidance of dialysis, is 92% renal survival in those that were treated versus 60%. Again, this third of the patients that go on to progress to end-stage renal disease. And at 10 years, 88% have achieved some remission, either partial or complete, and 47 of those were complete remission. So a lot of great evidence. There's another study from India that uses the same regimen and basically showed the same thing. These were 100 patients either treated with supportive therapy or with this modified Ponticelli regimen, and very similar results. So renal survival was good with treatment. The composite evidence of death, dialysis, or 2 times baseline creatinine was also better for treatment, with similar levels of complete or any remission, partial or complete. KDIGO also gives you the choice as an alternative first-line agent of using calcineurin inhibitors. And there's some data from Toronto looking at cyclosporin with low-dose prednisone. I'd like to highlight a study from the Spanish group that used tacrolimus monotherapy. And I think it shows pretty much the same results as cyclosporin. So the higher bars here are patients who are treated with tacrolimus at this dose for 12 months and then tapered over 18 months. So the course of tacrolimus was done at 18 months. And you can see very early on you get more partial in white here or complete remissions. So at all these time points, it's better than conservative therapy. However, after 18 months, 9 of the 19 patients relapsed in a very short time, between 2 and 7 months. So by 30 months after the start of treatment, there wasn't a whole lot of difference. So even though the probability of remission, and they cut this off at 18 months, looks very good, some of this is probably due to the hemodynamic effects of tacrolimus and the calcineurin inhibitors being vasoconstrictive and having an antiproteinuric effect alone. So it's a choice. And I've certainly used tacrolimus in my patients and had some good effects. But there are limitations, as we noted. So the calcineurin inhibitors can aggravate hypertension, they can worsen the GFR, they can cause interstitial fibrosis, striped fibrosis with prolonged use, they can be diabetogenic, and as noted, there's a very relatively high rate of relapse on discontinuation. But the first-line agents, alkylating agents, have a cancer risk, especially in smokers, risk of infertility in women more than men, and are diabetogenic as well with the steroids. So back to our case, the nephrologist and patient agreed to start a regimen, the Ponticelli regimen of cyclophosphamide and prednisone. And the nephrologist continues to follow the anti-PLAR, and within 3 months, the titer has declined substantially and then has completely disappeared by the end of the 6-month treatment course. So let's go to the audience response. What's the next step now? So the patient's renal function at the end of the course has remained stable with a creatinine of 1.1. Blood pressure, volume status are well controlled. There's no more edema, but he still has nephrotic range proteinuria at 5.2 grams per gram of creatinine. So what's your next step? And I apologize for the typo here. Start tacrolimus at the recommended dose in divided daily dosing. Give a gram of rituximab, followed 2 weeks later by another gram of the B-cell depleting agent. Repeat the course of Ponticelli. Start mycophenolate monotherapy, or continue your supportive therapy. So I'm going to cut this a little quickly because we're running short on time. Okay, good. So 3/4 of you chose the right answer. The majority of you started the other alternate therapy, which certainly, if you had no response, would be the right answer. So all of these A, B, and C would be reasonable if you didn't have. So his proteinuria came down from 10.7 to 5.2. So it's heading in the right direction. Plus, we know that the antibodies have disappeared. So I would argue that this is the patient that we should continue to follow. And why is that? So in the 10-year data from both the Ponticelli and the Indian groups, it's just a 6-month course of treatment. But look where the complete and partial remissions come. So the treatment duration is here, and you start to see any remission or complete remissions coming at 1, 2, 3, 4, 5 years out. So it takes time for these deposits to go away, for the podocyte and glomerular filtration barrier to recover. So you need to give the patient a little time to show evidence of responding. Another interesting paper that came from Jack Wetzel's lab in the Netherlands, they looked at 2 of their cohorts retrospectively, patients treated with cyclophosphamide or mycophenolate. And they took those patients that they knew from saved banked serum had anti-PLA2R at the start of therapy, positive at the start of therapy. And then they looked at the end of the treatment course, what had happened. Had they gotten rid of the anti-PLA2R or was it still there? So those that went from positive to negative, 58% of those remained in remission, didn't relapse by 5 years. In those that were still positive at the end of treatment, all of those relapsed, and often quickly within the first 2 years. So I think it's important to consider checking anti-PLA2R at the end of therapy to see if your treatment has had an immunologic effect on the disease. So back to our case, patient is indeed continued supportive therapy, followed with periodic checks of his urine protein. Over the next year, his proteinuria gradually decreases down to 0.2 grams a day, so complete remission, and his kidney function remains stable. As a good nephrologist, you follow him every 6 months, checking his renal function, his proteinuria. And 4 years later, after the initial episode, he's found to have a proteinuria that is now back in the 1.8 grams per day range. Proteinuria continues to increase. The creatinine is now rising. The patient isn't biopsied again, but the anti-PLA2R is checked. Turns out to be positive again. The patient looks at some literature that again has come out of the Jack Wetzel's labs in the Netherlands, that the use of cyclophosphamide in membranous nephropathy is indeed associated with an increased cancer risk, so he refuses to be treated with this again, and the nephrologist suggests rituximab. So what do we know about rituximab? We know there are no randomized controlled trials. There's some ongoing. The Mentor study is going on in America and Canada. The Starman trial is going on in Europe. There's a study in France, GEM-RETUX, that just published 6-month outcome data against supportive therapy. But currently, they're only observational data. We know that there are good effects when it's used as first-line therapy or second-line therapy, but there are issues with cost and insurance coverage. Just to show a picture, this is from the Ruginenti Ramuzzi's group in Bergamo that treated about 130 patients with rituximab, either as first line or second line. And the numbers look very similar to first line therapy with alkylating agents. So it looks like a promising agent. We're certainly using it, but we do await the randomized data. So our patient comes back, is treated with rituximab, the anti-BCL agent, and by 5 months after treatment, the anti-PLA2R has fallen by 40%. But because it's not a larger fall, the nephrologist plans another treatment of rituximab. But the patient is lost to follow-up and misses his scheduled visits. Now, why is this an issue? We know that patients treated with rituximab will have a depletion of B cells. And if you look at those who have achieved complete or partial remission by proteinuria, those are the ones that also had a decline in the disappearance of anti-PLA2R. It's those patients that have not had the decline in anti-PLA2R that don't remit. So this patient only had about a 40% drop, so wouldn't be predicted to have a response. So that's why the nephrologist wanted to treat with a second course at 6 months. But the patient never showed up, and 2 years later you find that he's now made it to end-stage renal disease and is on dialysis. His wife wants to donate a kidney, and the transplant nephrologist checks the serum and finds he's still positive for anti-PLA2R. So I'm just going to go through this quickly. I think we have 3 minutes left. You don't need to do the audience response. So which is correct about membranous nephropathy? Does it rarely recur in the allograft? Or is there a high likelihood of recurrence, but it's often mild and you don't need to worry about it? Or the correct answer is it does recur in about 40% of cases, and it can lead to graft loss in those who have high levels of proteinuria. So the centers that report this, 10 to 45%, the centers that do protocol biopsies at 1 month, 3 months, are the ones that report the higher rates of recurrence. So the Mayo Clinic is notable for this. Those that look at clinical recurrence, which may occur a year later as the proteinuria slowly progresses, find a lower incidence, about 10%. But what we know is that if you do have persistent nephrotic range proteinuria in the graft, this puts you at risk for graft failure. And just a note that anti-PLA2R can be associated with recurrent disease, but not de novo. So I'm getting towards the end here. There are a few studies like this. I was involved in this one looking at the Mayo Registry. But investigators have asked, does the presence of anti-PLA2R pre-transplantation predict whether or not this patient will recur? So in this series, all these patients had membranous nephropathy in their native kidney and then were transplanted. Those that were positive for PLA2R at transplantation, many of those recurred, 83% positive predictive value. But those that were negative, there were still some recurrences. So the negative predictive value really doesn't tell you much. Probably, this series included protocol biopsies. So if you only looked clinically, you may not have seen such a high rate of recurrence. We also know that in those that were negative, some of those may have had PLA2R-associated disease that was in immunologic remission, and we wouldn't expect any recurrence, maybe these 5 patients. But maybe some of these other were immunologically positive for antibodies to other antigens, like 7A. So I think it's tough to tell at transplant, unless you know that patient has PLA2R-associated membranous by virtue of staining their native kidney, what a negative and positive test mean. So we're still looking at this, but what I want to say is that if you are positive at transplantation, that by no means precludes you from getting a kidney. It just means you need to watch more carefully to see if those antibody levels are declining on their own or might require another agent, such as rituximab, to put this disease into full remission. So back to our case, the conclusion. The patient does receive an unrelated kidney allograft from his wife with good function, and just with the transplant immunosuppression of prednisone, tacrolimus, mycophenolate, the antibody levels decline slowly, and he has no clinical remission. Perhaps if you had done a protocol biopsy at 1 month, you might have found small deposits, but clinically insignificant, and they went away. So I'll just go through do I have time for take-home messages or? Okay. So we know that PLA2R is the major autoantigen in primary disease. THSD7A has emerged as a minor antigen in about 3 to 5% of cases. We know that testing for antibodies to these antigens, as well as staining the tissue, has impacted the diagnosis and monitoring of disease. And with this new immunologic window, I think we know that the clinical manifestations, proteinuria, lag well behind the immunologic course. So it's important, I think, to keep track of both. And that because the proteinuria persists after the disappearance of antibodies, it's important not to conclude that even if a patient is still proteinuric and their antibodies disappeared, that they need more treatment. I think you can watch those patients. You expect their proteinuria to come down over the next few months. I just want to say what a negative test might mean. So it could mean that patients in immunologic remission already, stain the biopsy to see if they were positive for PLA2R. It could be a different type of primary disease, such as that caused by antibodies to THSD7A, or it could be a secondary disease. Maybe these are the patients we should screen more closely for cancer. We know that serum albumin, especially below 2.8, puts the patient at risk for venous thromboembolic events. In terms of treatment, the alkylating agents and the calcineurin inhibitors remain the first-line or alternate first-line agents. We also know that there are many adverse events. So rituximab is a promising agent, and I think we should await the randomized controlled studies that are going on to compare them to existing agents. We know that membranous can recur in the kidney allograft in up to 45% of those that protocol biopsies are performed on, and that anti-PLA2R seropositivity just before transplant probably increases the risk of disease, but shouldn't be taken as a means to exclude the patient or have them treated before donation. We know that rituximab, if a patient does persistently have anti-PLA2R and has increasing proteinuria in the allograft, in spite of transplant immunosuppression, that rituximab is the agent of choice for treatment. So I think that may be it. And in your notes, I have some references in case you're interested in reading more. Thank you for your time.